Hiya, I'm Teoh, obstetrician, gynecologist and fertility specialist in Perth. This video is about choosing private obstetricians. The reason I'm making this video because for the past couple of weeks I've had 3 or 4 inquiries asking about the same questions. After speaking to my secretary, Natasha informed me about the inquiries, and I ended up phoning the patients to speak to them myself. So first question will be about the cost. Often obstetricians, private obstetricians would involve the patients, roughly how many visitations or consultations they have and how much would they cost, the management fees and the hospital admissions, etc., etc. Now, number one, this is for patients with insurance. If there's any events or anything that happens during pregnancy that you need to be admitted to hospital, this is where the private insurance come in. They would cover your cost of hospital care. Of course, not everything. There could be some small, relatively small plus. Sometimes not covered. It's complicated for me to explain today, but mostly it'll be covered. You can be reassured. And then they might say, look, what if I need to see you either in your rooms or in the hospital? You need to see me every day or every few days or every week. Now my answer is, on top of what the fees that you have been informed, i.e. you can predict or you can calculate, do the sums and say, look, how much you'll be out of pocket for the outpatient appointments where it's not covered by the insurance. Now on top of that, if I need to see my patients even every day, every week, every few days, I do bulk billing. So for me, then you won't have paying extra just because you need to see me a bit more. Those will be bulk bill. So I think it's fair because we have management fees and other routine clinic fees which should cover all those unexpected events from my point of view. Now the second question would be, what if I go into labor early? What in the hospital I choose can't cover that? Now it's very much depending on your team in that case. For example, certain hospitals, most hospitals privately would deliver patients from 34 weeks. Subiaco can go down to 30 weeks. But anything below that, mostly privately, you'll be referred to King Eddie's. A handful of doctors, very few, would be willing or would be able to continue to look after patients privately in King Eddie's, which I do that myself. So if anything, a patient need to be admitted to hospital or sometimes deliver below 30 weeks, then I'll look after them in King Eddie's privately. If above 30 weeks but below 34 weeks, then I look after them in Subi. Even if they are booked in other hospitals, I can bring them to Subiaco. So that's the answer for me. Of course, you have to ask your obstetricians that you are researching or you're thinking of booking in. See what they say. What's the answer? The third question is, many patients have different birth plan or birth preferences, and very commonly they'll ask questions about number one, pain control, epidural, and number two would be things like delayed cord clamping. When do you do cesarean section, etc., etc. So number one, pain control. Certainly I give my patients all the choices. If they can get along or they can withstand or they have strategy to cope with the pain with many things like hypnosis, TENS machine, relaxation, gas and air to use it to control the pain, then it's brilliant. I have patients delivering don't need it epidural. People often ask about epidural. Look, it is a very good pain control, but if you don't need it, then that's fine. It's there for you, and the stitches will be ready. But one thing I want to mention is Bear in mind, for example, look ahead for next hour if you need epidural. For example, some patients might thought, look, I can tolerate the pain until the stage that they say, look, no, I can't tolerate, I need it within the next minute. The thing is, it may not happen that quickly. Anesthetist could be around, which is great, or sometimes they're doing another epidural, or they're just finishing up something before they come in. There could be a lack of 20 minutes, perhaps, rarely longer. And when they set up things, put it in, it could be quite a while before epidural starts to work. So I often tell my patients, look, it's okay to say, look, I can wait and see. If I don't need epidural, I don't need it, which is fine. Many patients don't need it at all. But look ahead in about an hour's time, roughly, to say, look, if I will need it then perhaps if you want it then for sure, then get it done a bit earlier before it's too late. Of course, some patients labor very quickly, which is not a bad thing. By the time they want epidural, then baby is just it's coming very soon, just sitting there. We say, look, we push and get the baby out, because by the time epidural is in, we need baby will be delivered by then. Again, may not be a bad thing from my point of view. The third questions will be, when do I do cesarean section? Now, if the patient is committed to aim for a vaginal birth, I think as a good doctor, as a good obstetrician, I need to give them the maximum chance of achieving vaginal birth or natural birth, essentially. So we do what we can to make sure the mom is comfortable. They can do what they can in labor, provided safety of mom and bubs, always number one, provided safety is not compromised. I will wait as long as possible if we can, as long as need to let the labor progress. If it's progressed slowly but steadily, I'll say, look, keep going even until late at night. I don't rush in and think they need to do a cesarean section just to save time. If it's safe, if mom and bub's doing well, just keep going, essentially. Of course, there's no guarantee emergency cesarean section can happen at any time, because if the labor is really not going anywhere, it's not safe to carry on, or it's not safe to carry on because baby is not coping, and then of course we need to go for an emergency cesarean section. And later in labor, cesarean section can be a bit more difficult, but that's where experience comes in. You want to do a safe and good operation to deliver the baby. And questions of course will be asked about vacuum or forceps. Now, epidural does generally, not for everyone, some people actually does even helps them to deliver naturally without any help. But overall, epidural does increase the chance of someone needing either forceps or vacuum. And if we reach a stage that a patient needs a little bit of help, it's very common, and well, not for everyone. If it's not necessary, don't rush in and deliver the baby by forceps or vacuum. But if the patients need help, then you can give a little bit of help, and they still need to push, do most of the work to help the obstetrician like myself to deliver the baby. We give a little hand to deliver the baby for them by vacuum or forceps. Perineal episiotomy is another question. I don't routinely do episiotomy. Comes with experience, I have to say. Sometimes you have to do it because the patient may be pushing and pushing, but there's a band down, in the perineum, in the bottom, to actually stopping them to deliver baby safely. I'll say, look, I may have to do a little snip to open up a little bit, and then baby can come naturally without any help at all, natural, totally natural birth. That is possible. Or sometimes look, it's gonna have quite a bad tear. If you don't do it, then you may have to do a small controlled episiotomy. But many cases, I use warm water to massage between midwives and myself, and sometimes patients do it just when you're in early labor to let it stretch, and often you don't need episiotomy at all. The last question is which I can think of, is a control cord, a delayed cord clamping. The see delayed cord clamping. My routine nowadays, I do delayed cord clamping unless we need to get the baby to give oxygen, whereas for example pediatrician is there or midwives, we think look, this baby needs oxygen more than delayed cord clamping, then we have to cut the cord and pass the baby to get oxygen or anything. Sometimes just the baby is a bit stunned, just need a bit of stimulation or to help to kickstart. Then that's different story. But many babies are fine. Then I do a delayed cord clamping routinely. It's my kind of default. Same as aiming for natural birth is a default. Patients ask me. Certain patients might choose to have different birth preferences, like because of their births in the past or because of anything in the health. They might say, look, or they might prefer to have cesarean section. Then there's a different story. But otherwise, default is aim for natural birth. That's a few questions. Certainly feel free to phone my secretary, or if need to, I can speak to you. Bye bye. See you.